Thank you, Dr. Najjar. I'd like also to thank the scientific committee of the conference for this opportunity to present about mental health in this conference. I'll actually start with a statement that may summarize the situation. Mental health is part of the health system. It's not isolated. So when health system get a cold, mental health services would be expected to get a pneumonia. Mental health is part of health. WHO has been saying that no health without mental health. Health is a state of complete physical, mental, and social well-being, and not only the absence of disease. According to WHO definition for mental health is defined as a state of well-being where individuals can recognize their abilities to cope with normal stressors of life, work productively and fruitfully, and make contribution to their communities. And this means that mental health is not only about mental disorders. Let's speak about the burden of problem globally. Mental health conditions are not rare conditions. 14% of the global burden of disease is related to mental health, neurological and substance abuse problems. About 30% of the total burden of non-communicable disease is actually due to these problems as well. 4 out of 6 of the leading causes of disability is related to these disorders as well, including depression, schizophrenia, substance abuse, and severe forms of anxiety and bipolar disorders. 1 from every 4 families in this world got problem related to mental health. So this table can be summarizing the mental health system key findings. Regarding the governance, there is no mental health policy in Libya, no mental health plan, no mental health legislation, no governance mechanism for overseeing the mental health services of the country. Financing, no budget allocation for mental health prevention and promotion. Very small budget, but it's difficult to estimate how much exactly, but we assume that it's below 1% according to several calculations that we have made during the assessment. More than 95% of the budget is going to the 2 psychiatric hospitals. There is no formal training program for psychiatrists as well as for other mental health professionals. Many mental health profession does not exist, as for example the psychiatric nursing, no occupational therapist. Medications are only available at the psychiatric services. This means when the services are very centralized, the family that would need to receive treatment once or twice every week, who are staying in Kufra, for example, would need to travel every 2 weeks to come to Benghazi, most probably 1,000 kilometers every 2 weeks to receive their medication, because medication is only available at certain locations. Information systems. There is no component on mental health on the annual health statistics, on the annual health reports. No national data collection system exists on mental health facilities. There is no epidemiological data available. Regarding the mental health service, as we mentioned, it's very centralized. It's mainly institutional based. It's mainly Tripoli and Benghazi psychiatric hospital. But there is 2 newly established services, one in Tripoli and one in Misrata. In Tripoli, it's an outpatient clinic at the central hospital, and in Misrata, it's the Misrata Mental Health Center, which provide outpatient clinics, and it started during the revolution, started actually in 2011. And it work in part-time basis currently. And in Sabha, there is 1 outpatient clinic that started approximately about 4 years ago. And as you can see, the numbers are limited, and this information was shared also by my colleague, Dr. Adel Tajouri. The number of psychiatrists is very small in the country. We include here actually a larger number of psychiatrists because we counted also the trainees. But the total number of qualified psychiatrists in Libya is approximately about 12 psychiatrists, qualified psychiatrists. Let's compare some data about human resource for mental health in Libya. Libya is considered an upper middle income country according to the World Bank statistics. So comparing Libya mental health professional human resource with other upper middle income countries, we find there is a big discrepancy per 100,000 capita in the number of psychiatrists, nurses particularly, but we don't find this deficiency in psychologists and nurses. But this is not very good news, because actually in the curriculum of psychologists and social worker, according to the assessment, they are mainly trained as educational psychologists. The clinical exposure in their training curriculum is very limited. So although this number is large, but actually this is not reflected on the surface. This is very relevant to the statistics that Dr. Adel Tajouri was showing. This is the WHO projected magnitude for mental distress and mental illness after a conflict. We differentiate between the psychological distress and the pathological conditions that we will call a mental illness. There's a big difference, actually. Actually, the difference would be in the duration of the symptoms, the intensity of the symptoms, the impacts of the symptom on social and occupational life. We'd expect after a conflict that this psychological distress would rise and include mild psychological distress 20 to 40% of any population. Moderate to severe psychological distress would be 30 to 50%. You put the summation for both, and you might reach actually a closer figure to what Dr. Tajouri has mentioned to us in his presentation. But as we discussed, this doesn't mean that these people have an illness. These are people who are showing normal reaction to abnormal situation. But there is a severe form. But neither of these, we don't have enough evidence that neither of these would be a predictor of developing into an illness. The evidence that we have is only about the protective factor. The most protective factors that we have enough evidence about is the family and the peer support during a conflict. The more the person after the incident is closer to his peer and his family, we know that this is a protective factor from developing an illness. There is a misconception that all illness after a conflict would be post-traumatic stress disorder. Actually, there will be doubling of almost all disorders, not only post-traumatic stress disorder. Depression could be related to this, and anxiety could be related, substance use problems, even schizophrenia and other psychotic forms. So mild to moderate mental illness, not distress this time, would rise from 10% to reach 20%. And from 2 to 3% in any population. This means any population would have 2 to 3% of people with severe mental illness even before the conflict. But then when a conflict happened, due to many reasons, maybe the impact of the trauma itself, maybe change of someone who is having a mild or moderate illness into a condition which is more severe, maybe the deficiency of medication and service and its disruption during the conflict. We don't know why this percentage would rise, but trauma itself, trauma alone, is not the only contributing factor, but it could be one of the factors, that this would rise from 2 to 3% to 3 to 4%. Let's apply this in one of the most affected cities in Libya as an example, in Misrata. And let's see how the figures would be. Assuming that the population in Misrata, based on the 2006 census, is 543,000. So you can see the figures here for the mild and to moderate and severe psychological distress, reaching up to 271,000 of the population of Misrata. And the mild to moderate mental illness would be 108,000. Would all these people need hospitalization? No, including the people with severe mental illness. With severe mental illness here, actually, we speak about people who can take care of themselves, of women who can take care of their children, who cannot go to work, who cannot take care sometimes of themselves. So we talk about severely disabled people by mental illness, and this percentage would rise actually from 10,000 to reach up to 21,000 in Misrata. So to summarize the key challenges of the mental health system in Libya, it's stigma. Stigma is deeply rooted, including even among professionals themselves sometimes. Limited access to care, human resource deficiencies, numbers, lack of availability of services, which is very centralized. The way the services are organized, mainly institutional-based, centralized, no monitoring and education, evaluation, and no regulatory body for the service. Quality of care with the focus on biological model, mainly psychotropic medication prescription, which, as we mentioned, is only available in certain locations, and there is no capacity building programs. One key event that happened on last April, it happened at the National Center for Disease Control, where representatives from different ministries and different governmental institutes in Libya and local NGOs has gathered together in a meeting, which remind me it was actually a smaller version of this meeting, where they come from all across Libya to discuss the key pillars and the key strategic direction for mental health system in Libya. They discuss in 4 groups issues about planning, coordination, service development, service for vulnerable groups, prevention and promotion, and they all signed a consensus statement, a roadmap about how it was named Call for Action for a Multi-Sectoral Approach for Mental Health and Psychosocial Support in Libya, and this considered as the roadmap for how the service would be directed afterwards. The call for action is calling for integration of care of people with mental disorder into program development in all sectors, respect, dignity, acceptance, and recognition of people with mental disorders, to foster high-quality, accessible, community-based mental health and psychosocial programs, to mainstream mental health and psychosocial intervention into the broader recovery, development, humanitarian policies, strategies, legislation, and intervention, protect and promote human rights of people with mental disabilities, and ensure resources are available to mental health and psychosocial interventions in Libya. WHO is always calling for mental health integration into non-specialized healthcare settings. This includes primary healthcare, and also we consider that integration into general healthcare, including opening outpatient department and inpatient beds at the general hospital, could possibly be successful way for expanding the service. And there was planning meetings at the National Center for Disease Control, where primary healthcare professional and mental health professionals from all different Libyan cities sit together to discuss how they could develop a strategy about this. And there was training of trainer for most professionals so that they can train the general practitioner. And these are the two current main Ministry of Health WHO projects, one in Misrata and one in Sabha. And these two projects has been having many activities and lots of success stories across its road, and still continuing. It started by the beginning of this year and continuing until next year, and focusing on south and west of Libya. Yeah, so would it be possible to have a change? We speak about a long road that may take actually years to be developed. But we look at this area in the psychiatric hospital in Tripoli, which was like this only 3 months ago, and if we look to the change only that happened. This photo is taken one month ago. This place is renovated and now will be used as the first day care unit within the hospital, and it linked to it. There is a greenhouse where patients will be receiving rehabilitation, particularly the long stay patients. So this rapid change that start to happen. If you get a visit into the Tripoli Psychiatric Hospital, you will feel the reform atmosphere, starting from the outpatient clinic and the change of the service there, the medical records, the start of this new community-based service, start of some outreach service. You will feel this reform spirit by the mental health professional who are in Libya, who are taking the leadership for this. Okay. One important achievement is the look into the future. In collaboration between Libyan WHO and Finnish mental health expert from Finnish side, Dr. Timo Tori visited Libya in April, July, and August, and drafted a document which is called Mental Health Policy Framework in Libya for the year between 2012 until 2025. The collaboration was implemented from the Libyan side by Ministry of Health and National Center for Disease Control, and from Finland side by the National Institute of Welfare and Health, and this process was coordinated by WHO. There is general principles until the year 2025, setting time frame and needed resources to develop community mental health centers in Libya, and establishing a clear policy framework on how to develop this and what's the needed capacity to develop it. Also, it focused on primary health care and inpatient and outpatient units at the general hospital, and moving the care from institutional based into community based. And this is the pyramid, the WHO ideal pyramid model for services, and adapted by the Finnish expert in this policy framework for Libya, how the services would look like, starting from the base informal care, support, and self-care, and reaching the top where a limited number of people actually would need this service, which is the inpatient units in the community. So the vision is mental health care and service in Libya can be raised to WHO and international standards, representing a guiding role model for the region. It's possible. This can only be achieved through your help, not only through the mental health professional, through the general health experts who are meeting in this room. Can be achieved through mainstreaming mental health care into all the current upcoming healthcare development programs. So this is a website which is currently being developed by the Ministry of Health and WHO and contains this document as well as other documents. Thank you.
Thank you very much, Dr. Fahmy, for this interesting talk with some frightening figures, actually. Any question? We can take just one or two questions, please, because of time. Okay, then. So no questions. Please. Yeah. Go on.
Yes,
في ميكروفون مايك وين؟
And that's a problem in itself and lacking. So what is the overview and what is the advancement which we have to do to get to that level? I mean, there's a lot of companies doing the information collation and all those things, but I don't know about the future of the system in here. Thank you.
thanks. I think we are short of time, and then now I have the honor to introduce the next speaker, Dr. Maria Anitilla. Dr. Anitilla comes from the National Health Institute for Health and Welfare of Finland. She has worked on international health issues for over 20 years and also as a health advisor for the Ministry of Foreign Affairs of Finland. And Dr. Anitilla will present the findings and recommendations of the work done by the Finnish expert team that assessed the primary health care in Libya. Dr. Anitilla, be brief.
Do you have a quick comment, Dr. Fahmy Bahjat?
I think it will take some time to respond to Dr. Bashir during the coffee break.
Okay. Thank you very much for your appreciation.
Because we are short of time.
Thank you.
Be brief, please, Dr. Anitilla. This is for the next speaker as well, please, because we are short of time.
Thank you very much, Mr. Chairperson. And I feel very humble standing here and speaking to you about primary healthcare assessment to an audience who works in Libya and lives in Libya and knows these things, I'm sure, much better than the Finnish expert team that I was team leader for. But in any case, as was mentioned, I think yesterday by WHO representative, the Ministry of Health of Libya contacted early this year several organizations and also held discussions with the representatives of the Ministry for Foreign Affairs of Finland in Geneva and with collaboration with WHO. And there was an agreement that Finland would give technical assistance to support Libya's health system and services reform during this intermediate period after the conflict. So a team of experts from my institute, the National Institute for Health and Welfare, worked together with WHO office and Libyan professionals. And we were tasked to make a preliminary assessment of the situation of primary health care in Libya. And based on that assessment and discussions and visits to some facilities in Libya, review a little bit about the international experience and the discussion and the debate ongoing on primary health care, and then recommend some priority actions to revitalize the primary health care services. And we did produce a short document on this, a concept paper for Libya, which we will hand over to the Ministry of Health, of course, and WHO, and hopefully also can distribute then that wider. Oh, sorry. So what is primary healthcare? A brief recap again. The goal is better health for all, and it has how to achieve this. There are 5 key elements. You have to aim to reduce exclusion and social disparities, organize the healthcare around people's needs and expectations, integrate health issues into all sectors, not only talk about health sector. You have to have a collaborative policy dialogue with different kind of sectors and renew your leadership issues, and you have to increase stakeholder participation. Primary healthcare is designed really as to be the foundation of health service system. It's the first line service, but also we consider that it's important that primary healthcare is the provider of care for individuals with chronic diseases. And as was repeated, I think, in many earlier presentations, primary healthcare focuses on the person as a whole and not only on diseases. Primary healthcare on the national map of health services, we have heard about the gatekeeping function of the national health system, in the national health system. This gatekeeping function, if it doesn't exist or has not existed earlier, it needs a well-functioning primary healthcare service and also trust from the people who want to use it. And this change to a proper gatekeeping system may take very long to materialize. There needs to be a division of tasks and communication between the primary healthcare and the specialized services, and this is very country specific. Which level does this communication exist? What is the communication? There has been a good international experience on developing care guidelines or evidence-based guidelines, treatment protocols, if you may call them, and these can be only for primary health care, but very often they are for both primary care and specialist care. They give good guidance on who does what is the responsibility of which professional and which level. And I can't stress enough the fact that each country needs to specify the content of primary healthcare services themselves, itself. It's they who know the system, previous system, and also the health reform, including primary healthcare service, has to be designed and decided by the country authorities and people themselves. But internationally, this was one of our tasks, to bring in the international discussion and experience to this primary healthcare service concept. Primary healthcare consists of assessment, diagnosis, treatment, rehabilitation of new health problems. It's care of people with chronic illnesses, and importantly, it also includes preventive services and health promotion, so not only medical care. So as I said, the assessment that we made was very sort of thin and quick, and perhaps not at all so thorough and deep as the surveys and analysis that we have heard here before. There has been a good primary healthcare system, as was presented before lunch here, with primary healthcare posts or units, health centers, polyclinics. But we think, according to the discussions that we had with several experts and professionals and visiting several facilities, primary healthcare has sort of dislocated from its role as first-line contact. People are bypassing these primary healthcare services for multiple reasons. They don't trust the quality. They think that their disease is severe enough to deserve specialized care, so why go to get a referral from primary health care when you can go directly to specialized care? And facilities are not functioning. This is true after the conflict. There are not enough medicines. And primary health care doesn't, as it exists now, this is our humble view, it doesn't offer continuous, coordinated and comprehensive care. Doctors change, there is no proper referral system, narrow range of medicines, and they work on a reduced capacity. They maybe work only during the morning hours, but people need to go to get the services also after hours or in the afternoons. And there are no proper medical records kept. This is what we were told, at least, and maybe only a patient log, but not proper record, let alone health information system that you really can draw information and data and plan your activities from. More importantly, also, formal postgraduate primary healthcare training program is unclear whether it exists. Is there some earlier? Is it really specialization training, or is it just postgraduate on-the-job training or add-on training for what you already know? And division of tasks between specialist and primary healthcare is a bit unclear. I think it has been earlier, there has been times when it has been clear who does what, but now it's sort of blurred. And then funding for primary healthcare, we actually didn't quite grasp the whole idea of where does the funding come from, and do the primary healthcare units have any kind of saying in the funding, how the funding is allocated and so on. And then one big problem is how to ensure the funding in the future, because primary healthcare needs its separate funding, earmarked funding. Does it come from the central ministry or from local sources? And then again, what is the role of private sector providing primary health care and also other health services? You have heard many talks or referrals to this role of private sector here before. So what we recommended was that for the consideration of the Ministry of Health and those people who are responsible for the health service reform in Libya, is that perhaps you could consider establishing some kind of a pilot network of new and reformed primary healthcare centers, which may also serve as training centers for those who need postgraduate training in primary healthcare. And the functioning and the setup of these kind of pilot centers is really needs to be more detailed, discussed and talked about, but they should be this kind of a modern primary healthcare centers where you have a specialist or many specialists working within a multi-professional team. Then there's a need to develop a system of postgraduate training for primary healthcare doctors and also nurses, because at least in Europe and in Nordic countries, the nurses are very crucial in primary healthcare services. They do tasks individually and not only those that doctors ask them to do. Developing clinical guidelines for core health problems that are important in primary health care or feature often in primary health care, this would be our recommendation. Promote rational prescribing, ensuring that appropriate medicines are available is very important. I think we have a session on pharmaceuticals later. And then the funding system needs to be developed with appropriate autonomy to run the primary healthcare services. Of course, the funding system for primary healthcare cannot be developed without, the funding system for the whole health system, because it's a crucial part of that. And the staff working at the primary healthcare centers, units, polyclinics need to have some incentives to increase their productivity and efficient use of facilities. And then you have to work some kind of a policy how to work with the private sector. And what I want to lastly stress again and again is that this is a decision by the Libyans that you have to make which way you are taking your health service reform. And as foreigners, we only can give you examples of how things are in other countries, connect you with international experience. You have to learn from the good lessons and the bad lessons that other countries have had when reforming their health system, including their primary health care, and you really need to take ownership of this reform. Thank you very much for your attention.
Thanks very much, Dr. Antila, and we have no time for questions. Dr. Najjar will introduce the last speaker.
أستاذ محمد صالح إبراهيم مدير مركز المعلومات والتوثيق بوزارة الصحة يتكلم عليه facility assessment. محمد إبراهيم صالح, the director of the Information and Documentation, Health Information and Documentation Center in the Ministry of Health, will talk about facility assessment.
السلام عليكم ورحمة الله وبركاته. I would like first to start with taking the advantage of this opportunity to thank WHO, IMRO, for helping the Ministry of Health in Libya for conducting this post-conflict health assessment survey. And maybe it is a chance also to mention that special thank to Dr. Samir bin Ahmed, who I think should be available here somewhere in this event. Bismillah ar-Rahman ar-Rahim. You see, actually, what you see from the data is actually divided into 23 districts as before, because we don't have actually any new really districts borders in Libya at this time. Post-conflict context often poses significant changes for the health system and the new government, including its Ministry of Health. Urgent interventions need to undertake and alleviate the conflict impact on the system and to restore the pre-conflict functionality. This is the first thing. The second thing, SARA for Libya was conducted to assist the health sector in assessing and monitoring service readiness and capacity at district and health facility level, assessing the equitable and appropriate distribution of these services and resources, as well as providing the sector with the skills and tools for monitoring services and restore and resource availability on a regular basis. The objective of the survey actually are 4 objectives: assessing the current status of infrastructure, service availability. The second one, assessing the facility readiness and any damage which could have happened, sustained during the conflict. Managing system output, surface utilization and their adequacy, and assessing the system function, governance, including the level of organization, management, and the administrative capacities. Methodology used here, the surface availability and readiness assessment. SARA actually is the tool initiated or created by WHO. It is for surface availability and readiness assessment. It's already, they have this tool already ready with them. They just have adjusted it for Libyan situation. Provided a key information in the state of health system in terms of surface accessibility, density of health facilities and beds, core health workers, surface utilization, and go on. Survey tool, the survey utilizes the tool developed through SARA and modified to Libya context. The SARA is designed to provide key information in states of health systems in Libya, health system in Libya in the following areas: general surface availability, general surface readiness, and specific surface availability. And it will be explained later on. The SARA questionnaire consisted of sets of questions measuring surface availability and readiness, 340 questions for primary health care, and around 325 questions for hospitals. You can see what's surface availability means: health infrastructure itself, health workforce, surface utilization, and surface availability index. For the general surface readiness, basic amenities, basic equipment, standard precautions for infection prevention, diagnostic capacity, essential medicines, and general surface readiness. For surface specific availability and readiness, there are list of services, starting with antenatal care services, basic obstetric care, children surface routine immunization, and the list, as you can see here. For the short of time, I can't really go through it, but you can read it. Selection of the health facilities. Actually, it was decided from the beginning that all the health facilities, primary health care, all hospitals should be included in this survey. It means what's called a census of a public primary and secondary and tertiary health care facilities, primary health care or hospitals in all the districts of Libya. So it should be very clear here: primary health care is polyclinics, communicable diseases centers, and primary health care centers and units. As you can see here, it's the primary health care, polyclinics, communicable disease centers, and then primary care centers and units. Here, secondary health care, it's general hospitals or rural hospitals, and then tertiary health care, specialized hospitals. So what's the data collection and processing? It's actually the preparation started in late 2011, and then the first workshop for training the interviewers and the field staff was in January 2012 in Benghazi, and the tool was tested in Benghazi also by visiting some facilities in Benghazi. 126 staff actually were involved in data collection in the whole country. Actually, we collected all the data from all the interviewers. Actually, in time, it was around April or something like this for the primary health care. And then, by the help of IMRO also, a consultant was sent to us, and they trained the data entry staff and CS Pro software and 10 PCs in the health center and health information center, and all the data were entered before really by July 2012. The data also were sent for analysis in IMRO. For hospitals later than June, because the hospital questionnaire is different than really the primary health care questionnaire. We have two questionnaires. The questionnaire of primary health care was in Arabic, and the hospital questionnaire was prepared later in English language. and we had to really to use some of the doctors actually to visit health facilities and to have this questionnaire completed. This is just the photo where the actually the first training course done in Benghazi. Survey coverage, actually, as I have already mentioned, actually all the hospitals and all the primary health care centers covered. 1,379 public primary health care were completed and surveyed, and also 92 hospitals also completed during this survey. And the data both for primary health care and the 4 hospitals are entered and re-entered. For the hospitals and for the primary health care, we enter the data and then we re-entered all the data again so that we avoid any mistakes. This is the photograph of some of the primary health care facilities. Now, after entering the data, all the data is showed here in a GIS map, as you can see. So all the primary healthcare units are shown here, and after completing the entering this data and the analysis also. Now here the health centers, as you can see also how it is scattered all over the districts in Libya. Here the polyclinics, and then here you can see all the primary health care facilities are health units, health centers, polyclinics, and also rural hospitals. As you can see here, you can go and select any one, just want to show other primary health care units, centers, polyclinics, or rural hospitals, or other hospitals, so you can be shown in the map. Now, let me go shift to some of the results here. Actually, if you go to quickly here, you can see it's only for 449.
أستاذ محمد
نعم.
سمحت أسرع شوي بس.
Okay. Actually, let me then better go here where it's shown by in the map. So you can see here it's only 33% are fully functioning from the primary health care, and 44 are partially functioning, and 18 are not really functioning. 5% are under renovation. You can see here basic health services. Also, we selected some of the health services only to be shown, and for the time sake, I'll go to here. The facility providing the services, you can see here, for example, adolescents and school health services are only 24.8% are providing this. Antenatal care are only 22% are providing. Child immunization only 41. Pharmaceutical services are around 70%. Distribution of health facilities by region, this is by number, but it is better if you see here by per 10,000 of population, and you can see really a huge differences in between cities. For example, in Tripoli, it is less than one facility for 10,000, but in some areas are around 6 facilities for the 10,000. For the hospitals, you can see here all the hospitals are shown in this map because we use a GPS to locate all the hospitals and health facilities. Now you can see here the map. Here you can see the number of beds for each district, as I showed before. You can see here, it is better if you see the percentage to each 10,000 of the population. And you can see some differences, although some cities like Tripoli or Benghazi, actually, as we know, all the specialized hospitals are placed there. That's all I have.
Thank you very much.
في
We
أسرع
may
من-
take one or two questions, please, because of short of time. Yes, please. You please, and then Dr. Samir. Go ahead, please.
Thanks for the presentation. Just a quick question. This was mapping just public facilities. Could a version of this tool be used to map private facilities and to use the tool to see what is the distribution of the total facilities across the country? And is this being done in
Yes, actually, our program was also the private sector, but because not all the private facilities surveyed, so we did not enter them here. But we have got some of them, and I think we are going to complete them in near future. This is what we actually planned. All the facilities should be available in this survey, but we started with the public, and we are going to the private.
Thank you. Dr. Samir, please.
Very shortly, I wanted first to congratulate Al-Hajj Mohammed and his team for this excellent work. But I wanted also to insist on the outcome of this project. Actually, it is a dream for any decision maker in the health sector. At the end of this project, you will see the catchment area for each health center, each hospital. You will see, you can deduct from the database they have what are the services that need repair, strengthening, human resources, and financing. You have now a new parliament. Members of the parliament will be asking to build the new institutions. With the catchment areas, it will be obvious immediately which area needs a new institution and which area is overcrowded with institutions. And this project, which is a global project, has been implemented not first, but in the best way in Libya, and we intend in WHO to complete in Libya and then to make it a model for other countries as well.
Thank you very much. I know.
Quick addition.
Quick comment, please. Yeah.
Yes, it is really a very important point that Dr. Samir mentioned. No one single facility knows the catchment area. All the questions about the catchment area are not filled because they say that it is an open system and everyone can come. We don't know what's our the domain of our catchment area.
Thank you very much. I know the subject is very interesting and we can have loads and loads of questions, but we leave that to discuss that in the workshops. Thank you very much for all our speakers, and thank you very much for the audience and for the participants. And I'll leave the last word for the chairman. Thank you.
Chairman of National Support Group, Assistant Professor, and Head of Department of Zawiya University, BH Clinical Pharmacy. BH in Clinical Pharmacy and BH in Health Promotion International Expert in both fields with serial publication in both including books and book chapters. وكان دكتور عبد الواسط.
السلام عليكم. at the beginning, I would like to thank the organizers of this conference for inviting me to give this presentation. It's a presentation on the country current pharmaceutical situation. I would like to analyze the country current pharmaceutical situation, then go briefly through the possible reasons for such a situation and provide some recommendations for the future. The presentation is of introduction, then definitions, then current situation analysis, then recommendations. I'll start with the introduction. An increasing number of pharmaceutical products, as you well know, are available worldwide with rapid growth in consumption and expenditure, and the situation worldwide that some medications are not available or too expensive, or there are no adequate facilities or no trained professionals to prescribe or dispense these pharmaceutical products. Drug costs are increasing with a large share on the health budget. The situation is of lack of access in several countries around the world, poor quality, irrational use and waste. Changes in patterns of diseases, rise of new diseases led to increased spending on health expenditure. Changes in life expectancy and lifestyles also added up the increased cost on drugs and according to the health budget. Therefore, the WHO and member states decided that there should be a common framework. That's the national drug policy, which includes a system of indicators in order to measure and in order to improve the situation. So there is a list of indicators to measure any country pharmaceutical situation. I will try to define briefly each one of these terminologies. National drug policy, which is a commitment to goal and guide for action. It expresses and prioritizes the medium to long-term goals for the drug plans and future requirements of the country. It is a framework of activities of the pharmaceutical sector. There are a number of objectives for the national drug policy. These include access, quality, and rational use. There are a number of components for the national drug policy. These include selection of essential drugs, accessibility, affordability, drug financing, and the other ones. Essential drugs is those that, it's the list of those that satisfy the priority health care needs of the population. They are selected with due regard to public health relevance, evidence on efficacy and safety, and comparative cost effectiveness. They intended to be available within the context of functioning health systems at all times, in adequate amounts, in appropriate dosage forms, with assured quality and adequate information. Although originally they were intended to be utilized by developing countries only, but then the concept was taken over by even developed countries and in the West with different terms or names. So most of WHO member states use national drug lists, and they are called with different names. Pharmaceutical care is the responsible provision of drug therapy for the purpose of achieving definite outcomes that improve the patient's quality of life. Pharmacoeconomic analysis is something which is similar to health economics, but it's related to the comparing two pharmaceutical products or two pharmacy care services in order to be cost effective. And this means that not any new drug or any new product or any new intervention means that it is cost effective. We have to calculate the cost and effectiveness for this to be pharmacoeconomic. Pharmaceutical care quality assurance is within the same concept of health care quality assurance, but it's limited to pharmaceutical services. Counterfeit drugs, as you well know, it's related to products that they are fake, as simple as that. They may contain no drug, or they may contain inappropriate quantity of the active ingredient. Substandard drug products, these are genuine drug products produced by authorized manufacturers, but they do not meet the required specifications either in quantity or in quality. Other illegal drug products, these include those that are not licensed or those that are imported from unregistered manufacturers to the country. Generic drug prescribing, it describes the use of prescribing of non-proprietary titles or non-brand names or non-trade names of pharmaceuticals, which is a concept that is being used worldwide, including those rich countries. Pharmacovigilance is a structured process for the monitoring and detection of adverse drug reactions. Standard treatment guidelines, these are systemically developed collection of statements designed to assist prescribers' decisions about appropriate health care for specific clinical circumstances. Drug and Therapeutics Committee, they represent as an advisory committee to the decision makers in the hospitals, and they develop drug policies within hospitals. They evaluate and select and so on. Rational use of drugs is about appropriate use of medicines by prescribers, by dispensers, and by the users, the general public or the patients. I will go quickly to the current situation, analysis of the current situation of the country. National drug policy. Disjointed efforts, drafted, incomplete, developed incomplete in 2003, never circulated, never implemented, never monitored, never updated. About 15% of surveyed pharmacists in a study that my students have conducted in the university, the surveyed 15% of the surveyed pharmacists think that there is only 15% think that there is a national drug policy in Libya. 85% do not think so. The majority of countries worldwide, at least 120, have a national drug policy and an implementation plan that's integrated within the health strategy. Selection of items to the national specifications list, which is called drug list or essential drug list, and each country has a name for that. There is no written policy to select new items, no regulation or system, no pharmacoeconomic analysis for new items, and only 15% of those surveyed think that there is a national regulation for a national drug list in Libya. Sorry. Nearly all world countries have an essential drug list with different names. Quality control, drug quality control, it's weak, unstable, no government serious official commitment or support. It lacks necessary legislation, regulations, policy, system, and special operation procedures. It has insufficient equipment. It lacks trained personnel. Only 10% of surveyed people think or trust the government quality control system in Libya. Pharmacovigilance unit, theoretically developed but never implemented. None of the surveyed people in the study think that there is a national pharmacovigilance program. Prevalence of counterfeit and substandard products, both circulate in Libya freely, especially during the last year and after the revolution. None of the surveyed pharmacists think that there are no counterfeit or substandard products in the country, and about a quarter of the surveyed people think that the prevalence of the counterfeit or substandard products is low. The WHO estimates worldwide the average is about 10%, with 1% in developed countries like in the US, and 30 to 50% in some developing countries like India or Egypt or some African states. The real situation in Libya, God knows. Accessibility, inadequate accessibility with time and regional variations. Only 5% of the surveyed pharmacists think that all drugs to treat chronic diseases are accessible by all Libyans in the public sector. Worldwide, the average is 80% of key drugs should be available. On the other hand, tons of drugs become annually expired countrywide in Libya, and they go to the normal garbage, to the normal waste. They are not treated professionally. Pharmaceutical products registration is not implemented in the country. No government determination or approval on the manufacturer's prices. Implementation is recognized worldwide in most of the countries of the world, if not all. Local pricing of pharmaceutical products developed in 2007 and suspended after the revolution. Implemented in most world countries. Public sector procurement and distribution system. There is a continuous organizational supply difficulties and acute shortages, and guaranteed transportation, storage, or distribution system. They are not according to the good storage practice or good distribution practice. Cold chain is not well maintained, especially in the remote areas. And none of those surveyed trust the local system. Private market, pharmacists, wholesalers, and importers, there are some malpractices exist. They operate with no licenses, some of them. In some of them, the owners and dispensers are not necessarily pharmacists, which is against the law. There is unguaranteed transportation, storage, or distribution system, and cold chain is not maintained in some of them. Rational drug use is not maintained in the country. National standard treatment guidelines do not exist, which should be the case, which should be available in 75% of the countries of the world. Hospitals, drug and therapeutics committees, there is no national regulation for that. In some hospitals they exist, but with no central guidelines, and only 35% of surveyed pharmacists think that there is a national regulation for drug and therapeutics committees in hospitals. Policy and control of resistance to antimicrobial drugs, not available. Pharmaceutical care quality assurance is not available. Generics prescribing, the regulation was developed but never circulated or implemented. World average rate of generics prescribing is more than 80%. And I believe most of you know that even the rich countries, including Japan, US, and the UK, now they enforce the generics prescribing, especially in the public sector, in the NHS, or with the insurance companies. Regulation of prescription and non-prescription drugs, not available. There was a regulation developed in 1981, which is invalid today. All world countries have 2 or 3 lists. They are regularly updated. Regulation on drugs that can be prescribed by each level of health facility, primary healthcare centers, rural hospitals, general hospitals, or specialized centers. There was one developed in the 1980s, never updated, and accordingly it's invalid. Regulation for controlled drugs, very old, developed, but it became invalid. Drug Information Center, not available. And most of surveyed people do not believe that there is an unbiased Drug Information Center in Libya. Drug promotion, unregulated, illegal, unethical, and unprofessional practices exist. Unfortunately, this is the situation. We like it or not. Most world countries developed ethical and professional drug promotion practices, less implementation in developing countries. Regulation for commercial agencies, theoretically developed but never implemented. Management and control of parapharmaceuticals, no policy, no regulation to control the importation, marketing, or sales of herbal products, traditional remedies, nutritional supplements. It's up to the person who is at the customs at that day. Human resources development. No strategy, no plan or program for their qualification or training. So let me go to recommendations. Before that, let me ask why we are in such situation. The reasons are complex and go beyond simple financial constraints. Libya lacks a goodwill, political, or government commitment. it was a well-organized disorganization. There is a lack of an adequate drug legislation and regulations and a stable or functioning drug regulatory authority with adequate resources and infrastructure to enforce the legislation and regulations. World countries report the presence of extensive legal and regulatory framework covering all aspects of the pharmaceutical sector, especially those within the developed countries. There is a systemic weakness and institutional instability and lack of reliable data. There is a weak priority setting, lack of planning, and bureaucratic budgetary processes. So, what shall we do? National drug policy cannot be successfully implemented unless there is a national health strategy where this national drug policy is integrated with and all complement each other. There should be a country, short, intermediate, and long-term strategies. Health sector short, intermediate, and long-term strategies. Primary health care is the pathway for efficient health care. If you can, you call it new public health, or I prefer to use the new terminology, which is health promotion, is the pathway for efficient health care. Pharmaceutical sector short, intermediate, and long-term strategies are required. We have to identify needs and set priorities. We have to set time frames. Evidence-based planning and decision-making is an essential component of the future plans. Infrastructure is required. If you fail to plan, it means that you are planning to fail. Service quality assurance is required. Multidisciplinary, bridging the gaps is essential. Products quality control is a prerequisite. Extensive stakeholders consultation with all concerned sectors, all concerned